We would like to welcome our last presenter, Dr. Andri.
Okay. So it's not working?
Yeah, it's not working.
It's not working. Unfortunately. So thank you very much for the audience to come to this presentation, and also for the committee who have invited me to come to this lovely meeting. I believe that most of the participants are psychologists from the last meeting, and I want to introduce myself. I am a psychiatrist. Mostly I am dealing with the patient with anxiety and depression, and for somatic problems also. So today I would like to talk and to share my clinical cases about the psychiatric problem in elderly patient with vision impairment. So we know there are two kinds of problems with vision impairment in the elderly. The first one is the glaucoma, and the other is the retinopathy diabetic. So the first one I would like to mention here is the glaucoma. Is one of the group of eye disease that cause damage to the optic nerve and can lead to vision loss or blindness. And it is the leading cause of irreversible blindness worldwide. And talking about the glaucoma and psychiatric disorder, several studies have reported an increase of prevalence of psychiatric disorder among patients with glaucoma, including depression, anxiety, and cognitive impairments. And the exact mechanism is unknown still, but however, we know that the emotion is related to the chronic disease and the inflammation disease. So the psychiatric disorder may also affect the management of glaucoma. It related to the difficulty of treatment regimens and attending follow-up. So it means that it has some effects to the compliance of the patients also. So depression and elderly is one thing that we have to acknowledge today, that it is a common among older adults with an estimated prevalence of up to 10 to 15% in the community dwelling elderly populations. And several studies have reported an association between glaucoma and depression in older adults, with a higher prevalence of depressions observed among glaucoma patients compared to those without the disease. And the presence of depression may impact the management. As we said before, that it is potential having difficulty adhering the treatment regimens and also attending follow-up appointments. And the association between glaucoma and depressions may be bidirectional, with depressions potentially increasing the risk of developing glaucoma, and glaucoma-related vision loss potentially leading to depressions. So this is the case of a 75-year-old male patient of my clinic with a glaucoma for more than 2 years. His difficulty in sleeping that make him more anxious. Patients basically complain about how he was not satisfied with his ophthalmologist that promised him that he can see better if he get the operation. So patient was treated with Atifen, lorazepam 1 milligram, since he felt much worry initiating sleeping, and it worked for him. And we know that the lorazepam, I think we have to the studies next. I will try to get the ideas that using benzodiazepine to the elderly is sometimes very worrying to some clinician also because of the risk of the fall. But we tried clonazepam and astazolam, but he said that it couldn't make him sleep well compared to the lorazepam. But I have to confirm the patient that the regular check for his intraocular pressure was monitored by his ophthalmologist. How about the psychiatric medications and glaucoma? We know that the choice of psychiatric medications for elderly patients with glaucoma should be made on individual basis. because some is related to the patient medical history, medication regimen, potential risk and benefit. And it is important for healthcare providers to assess each patient individually and wait, and also have collaborations with other specialists, especially the ophthalmologists in these particular cases. And the antidepressant that we know that SSRI like fluoxetine, fluvoxamine, sertraline, and SNRI like duloxetine or Effexor or venlafaxine have been specifically linked to an increased risk of developing angle closure glaucoma. We know from the study, duloxetine is one of the that we have to prevent giving them to the patients with glaucoma, because it can get the bigger risk for the angle closure glaucoma in the elderly also, and which is less common from all the disease, but can cause rapid vision loss and makes patients more depressed. Another study published in the Journal of Ocular Pharmacology and Therapeutics compared the side effects of the benzodiazepine on the intraocular pressure in patients with glaucoma, and found that lorazepam and diazepam had the greatest effect on IOP, while clonazepam had a smaller effect. To these patients, we know that we use the lorazepam, so I think I consider that lorazepam because it has some good effects on the initiating sleeping and also have some effects on the anxiety, compared to clonazepam that has some effect to the anxiety but it get difficulty in sleeping. So the patients prefer to use lorazepam compared to other benzodiazepine, and he refused to use the sertraline or the other antidepressants because he said that it is not not beneficial for him, and it also get him nausea and also cannot sleep well because he's very anxious and make him get a headache. So it's just like a side effect that he cannot consider the side effects of this particular serotonin medication. And the other thing about the vision impairment in the elderly is related to diabetic retinopathy. So management of both diabetic retinopathy and psychiatric problem in the elderly may require a multidisciplinary approach involving healthcare providers from multiple specialty, including ophthalmologists, psychiatry, and primary care. And we know that the diabetes retinopathy is common complications of diabetes and can lead to vision loss and blindness if it is untreated. And study has shown that patients with diabetic retinopathy are increased of developing psychiatric problems such as depression and anxiety. And elderly patients with diabetic retinopathy were more likely to have symptoms of depression and anxiety compared to those without retinopathy. That we said before that the elderly has a more prevalence to suffer depression and anxiety also. And this is the case of 70 years old female patients, 67 years old female patient with retinopathic diabetic with declining of visions after surgery. He feeling disappointed just like the other man before, the other patients that has a complaint about this ophthalmologist that promised her to have a better vision after surgery. And the patient has persistent symptom anxiety for the last 8 months. Different from the previous patient, she was given escitalopram, the SSRI, 5 milligrams, and clobazam, 5 milligrams twice a day to relieve the symptoms, and they work for him. Maybe you asked about why don't you try to have some non-pharmacological treatment or non-pharmacological approach to these patients. We have tried to this patient, and we have talked to the patient and trying to consult the patient to the psychologist, but both the patients refuse to use such of approach, and then try to keep on the medications only. Psychiatric medications and diabetic retinopathy. A study published in the Journal of Diabetes Research found that escitalopram was effective in reducing symptoms of depression in elderly patients with type 2 diabetes, While the study did not specifically focus on patients with diabetic retinopathy, it did include patients with various diabetic complications. And escitalopram, as we know, was well tolerated, and it has some minimal side effects, effective in treating depressions and also in elderly with comorbid medical conditions, including diabetes and hypertension. So there is a limited research on the use of escitalopram, especially for the treatments of depression in elderly patients with diabetic. But I know that there is evidence, large evidence of using escitaloprams can be effective in treating depressions in the general populations of the elderly. So the conclusions from these cases, elderly individuals with vision impairment are at higher risk of developing psychiatric problems than their peers with good eyesight. And in my clinical practice, elderly with vision impairment sometimes it's more related to the depressions rather to the anxiety. First, they come with anxiety problem. Actually, you cannot sleep well, but after 2 or 3 months after that, they started to have a depressed symptoms. So vision impairment can lead to social isolation, decreased independence, and reduced quality of life, which can contribute to the development of psychiatric problems such as depression and anxiety. And if it is underdiagnosed or undertreated due to lack of access to mental health service, stigma, especially in Indonesia, surrounding mental illness and communication barriers, it can be very unfortunate for the elderly. It is important for healthcare professionals to screen elderly patients with vision impairment for psychiatric problems and to provide appropriate mental health care and support. In Indonesia, there is a PHQ-9 that can be very useful to recognize and acknowledge the depression symptoms. Interventions such as psychotherapy, medications, and social support can be effective in treating psychiatric problems in the elderly with vision impairment, although we know that some of the psychotherapy cannot be beneficial to the patient with elderly because of the social, cognitive, and cognitive declining of the patient itself. And the involvement of family members and caregivers in the care of elderly individuals with vision impairment and psychiatric problems can also be beneficial in improving their mental health outcomes. So thank you very much, and please visit Indonesia if you like. Thank you. Yes.
In your practice, if the GP or the general practitioner refers to you for a patient, do you regularly screen the patient for visual impairment or cerebral glaucoma? Firstly, into the practice screening. And the second question is, we commonly prescribe and we talk about falls and delirium, but rarely would we talk about visual complications. Is that something that you do when you consent in relation to side effects of antidepressants, or like relationship with antidepressants and visual impairment?
Okay. The first question about the GPs. Most of my patients are consulted from the specialists, especially the ophthalmologists or the neurologists. So it's very seldom to get the refers from the GPs. But in elderly patients, we frequent to use the MMSA to have a kind of like a brief report about the cognitive problems compared to vision, because of the vision is very subtle and very vivid, so sometimes very recognizable by the patient. So the patients first come with the I have done the surgery for about 4 months. So they first they will tell you first before we screen for the vision impairment in the elderly. And the second question about the using of antidepressants, we know that sometimes the using of antidepressants to the elderly is very challenging because of the side effects, and I think we start with the low dose, and the idiom of start low, go slow will still be the beneficial approach to the patients or elderly patients, especially with the medical problems or many medical problems like hypertension and cardiologist problems. So compared to I think it's just only the duloxetine that we have to be very careful when using it in elderly patients, especially with the problems with the vision impairment or glaucoma, because I'm never used that in my clinical practice, duloxetine for the elderly, especially with the vision impairment patient. Thank you very much.
Thank you for your presentation.
Thank you.
Very helpful. I learned a lot. Do you think the elderly patients that were resistant to counseling for mental health might, maybe if you called it education or some other element, would you find better acceptance, perhaps?
Yeah, in my clinical practice and my point of view related to the patients of the elderly, I think maybe the social background of the patients. Some of the patients are are willing to have a rapid rapid kind like a rapid improvement. So they thought the psychotherapy will not help. Just talking, just say that, like, even though we say that in our clinical practice we also the psychoeducation of the patients. How that how can he misinterpreted, both of the patient misinterpreted what of the ophthalmologist said about the operations. The ophthalmologist say that the operations will help to improve your insight, but the result is the opposite. So it means that he cannot, or both of the patients couldn't accept the reality of the patient. But she just both of the patients also complaining also about the anxiety symptoms, and the man or the male patients talking more about the insomnia. So they just when they see me, they just want to just cure my insomnia, just cure my anxiety. You don't have to talk more. I just want to finish this. But not so many patients like that. Some of the patients like to talk with us a little bit more, but some of the patients just given the medications, it will help me to get my anxiety rid off and I can sleep well.
Well, it's understandable. Thank you.
Thank you. Yes.
Because in your presentation you were talking about glaucoma and diabetic retinopathy. So I'm wondering that how cataract is associated with psychological disorders and so on.
Yes, basically the vision impairments in the elderly can lead to depressions also because it's chronic and sometimes. But I know some of the cataracts can be very improved by the operation. So most of the patients with cataract, they can see well as before compared to diabetic retinopathy, which is very chronic, and also the glaucoma, which is very terrifying because some suddenly can be blind totally. And I have also some of the patients with cataract, but they less anxiety and depression compared to retinopathy and glaucoma patients. Thank you. Yeah.
Thank you for your presentation.
Thank you.
I'm just curious about the patient profile for your glaucoma patient. So usually glaucoma surgery will not improve vision. It will just at best stop the progression.
Yes.
So in this case, is it a miscommunication
Yeah.
with the patient?
I think so. So maybe that's why we need to have a MMSA cognitive impairment, and we suggest that before doing surgery, maybe they have to to acknowledge them and then to recognize the problems of cognitive declining in the patients, and sometimes because of the maybe the intellectual intelligence of the patient, because they sometimes misinterpret, because some of the patient with the low economic background or low educational background, some misinterpret getting better with the operations that still can be like the young physicians, and then maybe because of the some of the ophthalmologists say that yeah, we already did well, and then there is no kind of like a malpractice or something like that. It's good, and it's done well. So I think yes, maybe because of the miscommunications with the patient and how to interpret the result of the operation.
So then the insomnia presented in that patient, what's the underlying cause? Is it idiopathic or is it based on
The insomnia? I think because of the anxiety. Most of the insomnia below 65 years old, if we see insomnia in the clinical practice, we know that the insomnia comes from the anxiety and depression. But after 65 years old, I think maybe some of the elderly become more like the circadian rhythms, the melatonin receptors that can be declined after 65 years old. And then it's very common in the elderly to have an insomnia. Yes.
You mentioned that your patient was presented with with glaucoma and he was on the lorazepam and they found that to be helpful.
Yeah.
Because I guess we do worry about falls risk as you pointed out, and I guess if they're visually impaired, then falls risk goes up even further. Like I'm just wondering with the lorazepam, is there any particular sort of way to sort of manage it or wean them off or to change them to something else, or is that kind of going to continue to look the same in the future for that particular patient?
I think when we are dealing with the benzodiazepine, we have to be very careful, and then we know that it's only half for the period, short period of time. Basically, we want that, but sometimes we do use this for the period of time, years sometimes, and
Because your patients, that particular patient didn't want to sort of go on necessarily.
yes, yes,
So yeah, you're going to continue that.
yeah. I I already give also the mirtazapine. We know that the mirtazapine sometimes has the kind of like a sedation effect and for the helping for the insomnia of the patient, and also has good effect for the depression. But yes, compared to benzodiazepine, he still want to use the lorazepam until now, because uh, his his son's also asking me about the some patients now they googling, and then they say that the benzodiazepine is not good. It can be dependence, and maybe
Yeah, I thought
can
it was kind of effective for a few months, but then I thought the effects sort of wore off, like my understanding.
yeah, some of the patients, but I think in our clinical practice, sometimes when we see the patients of 75 years old, and then they tend to depend on the benzodiazepines, yes, just for 0.5 milligrams lorazepam to 1 milligrams lorazepam, even sometimes to 2 milligrams lorazepam. We just continue the medications because sometimes it's better to use compared to the antidepressants like SSRI. Thank you. Yeah.
Perhaps I have a small story or comment.
Yeah.
Is that I'm from China, from northern part of China, and my grandma actually she has glaucoma, she has cataract, and she also got hip fracture. So if you can imagine that all these conditions together, so she go to I mean because I'm a medical doctor, so I can see that she got depression and also personality disorders. But the thing is that she lives in the countryside, and that is a kind of like a rural area.
Yeah.
So the thing happened is that she got insomnia, depression, and also delirium.
Yeah.
And sometimes she just say things that is nonsense.
Yeah.
So the things that my relatives who are taking care of her, and they started to looking for medium. those people who can see dead people, who can see the spirits.
Mm.
So they started consulting them, and they came to the place, to the house, and say that, well, perhaps there is a spirit of a dead
Yes.
relative,
Yeah.
kind of like leaving her body right now.
Yeah.
This is the reason why she is saying things that is nonsense.
Yeah.
So I think the mental health education
Yeah.
in rural areas is extremely important.
I agree. I agree. And sometimes we know that from studies we see that the patient with impairment, vision impairment, also has related to even sometimes with the dementia, and it has come like more like a BPSD. We know that behavioral and psychological syndrome of dementia, and the hallucination or the psychotic symptoms more related to the patients with more medical problems. And I think the hallucinations are likely more vivid hallucinations, like visual hallucination in the elderly also can be a sign of dementia, not only a psychotic patient or a schizophrenic patient. So I think we have to be very careful with that. And like you said, it has also some caution with the hip fractures. It also can lead to delirium sometimes, even in the very mild condition sometimes, and it can be suddenly, it can be trigger the delirium, and it's very have to be caution for us also when dealing with the patients with many medical problems like that. Thank you. I think time is up. Okay, thank you very much. Thank you very much.